to introduce Henry, who is the CEO of ADHD
Hello.
UK, Mel Webster, who is the CEO of ADHD Australia, Moonlake Lee, who is in charge of unlocking ADHD Singapore, and Darren Bull, who heads up ADHD New Zealand.
Kia ora.
Kia ora. How are you? So this section is called ADHD Without Borders, Understanding Global Variations and Cultural Insights. And we basically have three broad questions I'll ask each of you. Henry, as you're the person who is on, I'm going to ask you first, what was the leading issue or challenge that you've had the past year in the ADHD world that has consumed most of your time?
Man, it's been
Only one, Henry.
yeah, I mean, it's been pretty wild. I think the big achievement, the big thing, I know later we've got some slides, or we're each talking about the assessment process in our countries, to sort of compare and contrast and learn from. We have a very important access path called Right to Choose. So there's a national health service, but it's regionalized in organization. And that can lead to very big differences in how long you're seen. So in one area, we have over 6,000 people waiting, but for the year where we last have stats, they saw 3 people. So we have an effective wait time of over 2,000 years. And in another area, we've got wait times of 12, 16 weeks. There's a thing called Right to Choose, which is, to quote a commissioner, it's the National Health Service, the NHS, the National Health Service, not the Regional Health Service. And so there's a thing called Right to Choose, which enables you to be seen in another area. So if you're in Sheffield with 2,000 years to wait and got to learn how to mummify your body Egyptian style to last long enough to get to a assessment, you can instead go to the shorter place. They were going to put in and if you're Sheffield, obviously you've decided to devalue ADHD, you don't want to pay for it. So if you use Right to Choose, your local area has to pay for it, but you get the service in another part of the NHS. There were very big moves to change that. They were done in a sort of backwater part of the NHS called the NHS payment system. There was a consultation that was to last 4 weeks, then there's 4 weeks and then it gets implemented. And that was going to place a restrictive cap saying that where roughly 25 to 30 people per area would be able to use that. When you've got a wait of 6,000 people, then 25 people is nothing. We were able to put up a system for people to write to their MPs. We were notified of this happening about a week into the consultation. Week 2, we had a campaign writing for constituents to write to their MP. And in those last 14 days, we were successful in rallying the community to have 14,000 letters and emails written to their MP. Many MPs getting over 100. We have 650 MPs. And defending what is a legal right, the right to choose. If you put this cap in, it's not there. And we were successful in getting the government to U-turn. But we knew we'd won the battle, but not the war. And at the end of our session, we've got 2 political sessions coming up. One with a number 10 insider, who's the number 10 advisor for healthcare for Prime Minister Rishi Sunak, and before that in senior roles in the Ministry of Health. And we also then have the ex-head of mental health care for the entirety of NHS England speaking about the fact that there are now new right to choose controls being put in place and what we're going to do about it. But so that's been the biggest battle, and that's because our estimate is roughly 80% of people right now in England, that's how they get their ADHD assessment. So it is the dominant path, and it's trying to be stopped, and that would be ruinous. Back to you.
Where do you think this will end up, Henry? Like, if you were to look 1 year forward, what do you think is going to happen?
I mean, we are in a really fragile political setup right now.
Right.
So you have Labour, Keir Starmer, his statistics are now that he's the most unpopular Prime Minister we've ever had since we've been collecting those statistics, which considering that's now lower than Liz Truss, who was famously less successful than an iceberg lettuce in her Prime Minister ability. So for those that don't know, that she was considered to last such a short time. I think it was the Daily Star put a live video on an iceberg lettuce and said this lettuce will last longer than Liz Truss, and
But
it did.
did.
Like, um, and we have Reform, who have made some quite aggressive statements around neurodivergence, and there's a viewpoint that people getting an assessment means they then go on benefits, which is not what we see at all. We see people getting an assessment to thrive in life, but that view is one that's being held by people, and so that could make things much worse. We're not expecting an election for many years for the nation, but Wales has one next year, and Reform are currently polled to win it. So there's a lot of jostling, and we're seeing a lot of statements around support for mental health and it creating a benefit cost rather than being a support. But then you say to people like, what's happening is people are struggling because they're not getting support, and making that argument. We are going to fight tooth and nail, Rob, but it's hard to say what we expect to happen.
There are bigger systemic problems by the sound of it. Well, I mean, Darren, better or worse in New Zealand?
It's going to be significantly better. Over last year, the government have announced significant changes to the way ADHD is diagnosed and prescribed, which comes into effect 1st of Feb. It also, and that already in effect, removed the barriers to accessing ADHD medication once you've been diagnosed. So in terms of our focus, it's on getting ready for 1st of Feb. The main issue we have now are medication shortages, and Pharmac, which is our medicine body, have been great with the communication and looking for alternatives. So this change has been a long time coming. It's the biggest change in ADHD for 30 years in the New Zealand medical system. So yeah, better.
Very good. Very good. Moonlight, what's your take on things?
Thank you. Things are also looking better in Singapore. There's still not sufficient awareness about what ADHD is and the impact on people's life throughout the lifespan. But organizationally, for Unlocking ADHD, we turned 4 years old this month. So we really are the new kid on the block. And what is special this year, about 6 months ago, we received this status called the IPC status, the Institution of a Public Character. So what this means for a charity like ours is that donations to us are tax deductible now. Prior to this, they were not. And in Singapore, the law is 2.5 times the donation amount. So you can imagine when a donor has a choice between a charity that can give the tax deductibility and one that cannot, which would they favor? So this was a significant breakthrough because we are the only charity that's focusing on ADHD in Singapore that now has that status, and that actually has helped a lot. That's the first thing organizationally. The second thing that I'm really excited to announce just happened a couple of days ago, so it's breaking news. There's a very well-established regional conglomerate called Jardine Matheson that has its own charity arm called Mindset that promotes mental health. They have come on board alongside Unlocking ADHD with a Singapore $1 million pledge over a 3-year period to support us to establish for the first time accessible ADHD informed counseling services and other services. So
your lobbying efforts are starting to pay off, Moonlight.
Yeah, but it's been pretty hairy, okay, to say the least. But we're so grateful because it's such a significant move because this is a very well-established regional corporation that has multiple business units, including, like, say, Starbucks here. and pharmacies and real estate, and they have come alongside us because they recognize the importance of supporting not just on the mental health but a very often overlooked condition. So we've already got 3 counselors on board, and we're sort of ramping things up, and I still hope to attract more funding support because we're hoping to roll out executive function coaching and ADHD coaching next year. So that's the big thing as well. And we are launching a book next week, and it's called Differently Wired Minds. And this year, Singapore turns 60 years old. So to commemorate this, we call it SG60. We thought it would be meaningful to have a book featuring 60 Singapore ADHDers sharing their journey from all walks of life and all ages, all ethnic groups. But being ADHDers, sometimes we overdo things. So I didn't get 60, I had 63. But and, we also are going to be launching a video, the first public awareness video on ADHD called Focus on Us. And the reason why it's so exciting for the book and the video is created by ADHDers, featuring ADHDers, not just for ADHD community, but also for others to help understand us better and also show that there are ways that we can thrive. So for the book itself, even though there's going to be limited copies, hardcover available as a fundraising gift for those who donate to us of a certain amount, we're also making sure they're available on our website so that anyone and everyone can access the journeys, the strategies, so that no one is having a lack of access in terms of being able to get tools to thrive. So some things that are keeping us organized and busy, but in Singapore overall,
Is that it? Is that it? Is that,
it's very because our government now is updating the clinical practice guidelines on ADHD. So I'm on that team, and for the first time, adult ADHD is going to be included. So we hope to release all these things hopefully by end of next year. We'll update by then. Thank you.
That's
Wow.
awesome. It's an epochal year for you. That's
Awesome.
extraordinary.
Yeah.
Awesome.
Congratulations.
Thank
Like
you.
that's, I think we all know how much work you like that involves and how much you put in, and actually how extraordinary you are in your abilities to connect with people and get stuff happening. Right, I'm going to be needing to take some lessons. You're amazing.
I'm learning from everyone.
We're overdue for a trip to Singapore, so that sounds like a very good idea. Now,
Yeah,
I might
look,
stop you, and then I'll get you to double up on the next question too, which is
no,
what do you think's
not a
gonna
problem at all. Look, I suppose what's really interesting is probably for this the first time ever in Australia, we have seen significant changes this year. If you asked me this question, Rob, back in January this year, I would have said to you one of the most difficult challenges for us was affordable ADHD diagnosis, treatment. We had long waiting times, out-of-pocket costs, medication shortages and regulation delays, stigma continuing. We still have that significantly across the states. But what I would say is, for the first time ever, we've seen significant changes across different states, and we're hoping to see across all states of Australia. One of the biggest is the New South Wales ADHD reform. Government now is allowing trained GPs to prescribe ongoing ADHD medication for patients. This is a significant impact positively to individuals. Trained individuals being able to do this means that it reduces the resilience and the overload on individuals as a whole. It also means that now more people are going to be able to access prescribed medication in a way that they need to. The next stage is phase 2. It's the GP diagnostic pathway, which is super exciting because what it's going to allow us to do in some states, and again, ADHD pushing Australia hard for it to happen across Australia, but is basically for us to be able to look at initiating ADHD diagnosis for GPs, those specially trained to do so. That's really important. It isn't all GPs, it's those specially trained to do so. But this reform is going to change significantly for what we're trying to achieve here in Australia. Also, the expansion of telehealth in Australia has been huge. I think some of that is COVID related, but it continues to be fantastic in driving that, not just from a COVID space, but ongoing as we move forward. Schools also across Australia and also community are really starting to take that inclusive approach to strategies. We've had some amazing talks throughout the day from educators, whether that be universities, but also across schools, where schools are really wanting to and commit to making that change for individuals with ADHD and the community as a whole. So for the first time ever, Rob, I think, and you're here based in Australia, in Sydney, I think it's fair to say that it's a very exciting time for us. We've got a lot still to do, but at the same time, I think it's a significant shift to this time last year when I was speaking to you, Henry, and Moon Lake, and Darren and I didn't have the opportunity last year, but I think just being in New Zealand, you can hear, probably more aware of some of the changes we've had here in Australia.
Great news, isn't it? Being a resident of New South Wales and having family members that have ADHD, it was with excitement that we greeted that news. So yeah, very much so. Darren, changes coming forward in the next year, positive or negative, that you think that you'll be dealing with?
Positive. So the big change, very similar to Australia, because the Royal Colleges go across Australasia, and we're very much here building on the work with APTA, which is across both countries. It's positive because New Zealand will go to trained GPs diagnosing and prescribing from the 1st of Feb. And that will do a number of things that will reduce the wait times. We've got the wait times according to the surveys. We do it's somewhere between 3 to 6 months where you live, depending where you live in New Zealand, for both public and private. So we're expecting a few hundred trained GPs over the next few years to sort of come through. So it's going to have a real positive impact. The other aspect to it, they will charge. It will be estimated, still to be confirmed, $400 to $500. To go private, it's $2,000 to $3,000. And I've even heard of someone being charged $5,000. So that's the really big change. The challenge is now is to ensure enough GPs are trained. So the Royal College of GPs is doing a great job bringing it through, along with the University of Auckland School of Medicine. We're really, I just want to call this out, with this is the 10 years of work to get this far, but the work that APTA did in Australia we're really standing on their shoulders, and we're using the Australian guidelines here, which is fantastic, and also the NICE guidelines from the UK. And I can't overstate how important it is to have quality guidelines, obviously, but to bring on two pieces of really strong work from Australia and the UK means New Zealand doesn't have to build our own guidelines. There is the intention to do that, but we're in a strong place to do that. Yeah.
Excellent. Moonlight.
Yeah, I also echo the learnings from each other, and I think it really helps to shortcut the process, but also show the best practices. In Singapore, I think there are some movements as well, and I'm hopeful. One of the things that's recently launched is the Institute of Mental Health is doing a large population study for children within a certain age group, I think 9 to 16, and they're specifically trying to assess the prevalence for ADHD, ASD, anxiety, and depression. There really hasn't been any study of ADHD since I think 2014. So this is something big, and I think from what I understand, if there is some diagnosis, there will be further support given on the next level. So to me, this is very encouraging, and it's important because when there's more data, then people can measure it, then they know in terms of planning on how to address it. So that's important. And then from the mental health side, the Singapore Prime Minister, the Singapore government is very much focused on mental health. There's even special committees set up. So we're adopting a tiered care model for mental health. So tier one being community. So there's lots of effort here trying to get more people in the community to be upskilled, to understand mental health, to have the tools to support each other, so peer support, but also having a next level step up, the basic care, and then further on, so that at least the tertiary complex cases are sort of not creating, we're not having bottlenecks where they should not be. So I'm hoping that, in terms of how we want to roll out coaching next year and subsequently, we can also show that we're very much in line with this approach. So these are the two main things that we're looking at.
Awesome. Henry, in terms of what you think is going to happen over the next 12 months, we may have covered that, unless there's something you'd like to add. Otherwise, we might move on to the diagnosis pathway. What would you like to do there?
I think, yeah, there's too much happening all at the same time. Certainly, I think some of the lessons from what's happening in your territories, the GPs taking a bigger role is really important. We're seeing that conversation happen. We have they're called the Royal Colleges who take the lead on that. We unfortunately are dealing with a very large industrial dispute with GPs.
Yeah.
So there is a standard contract with GP practices. The current government has essentially foisted that on GPs. They were looking to negotiate for change. As a part of that, their union, the British Medical Association, listed 122 different things they could do industrial dispute on. They chose the predominant GPs have chosen 3 of those, and guess who's one of them? And so we are finding GPs aren't actually doing the reverse of taking over. We've had a thing called shared care where you get assessed by a specialist and the GP takes over your monthly reviews, and many GPs are now refusing to do that. And that's particularly significant if you've been seen privately, because then privately you have to pay the retail price of the medication, so 100, 140, 160 pounds every month, versus an NHS standard prescription of £9.90. So it's a huge difference, as well as not needing to go and see that specialist, some of whom will charge. And Darren spoke really well to the problem that we have really high price variability. So I know some places are charging £50 for that monthly meeting, and others paying 250. I mean, so then that's 250 plus 160, right? It's a huge amount every month. GPs are not only not accepting new shared cares, but in some areas they're dropping their patients entirely. And then you're dropping to a service that has a wait times of years. So it's a absolutely massive problem. I would like to say in most cases where that's happened, we have seen the central service. We get mixed messages on it, but it seems to be getting better at making sure people continue with medication. But what that then is doing is it means that those local services, instead of seeing new people, have to use their capacity to see current people. And so it's making the backlog even worse. So it's great hearing the GP initiatives that are happening in your areas, but we are clearly playing a completely different game. We're having to just play defense and trying to stop an erosion, whereas you're talking about progress, which right now honestly seems far away.
It's
but we are
interesting
definitely
because
fighting, and we definitely have a big community. 14,000 people.
It's clearly
right into MP.
In a lot of the territories for the GPs to take on these roles and responsibilities. I think in most instances it's paid for, and we'll talk about that in detail in a second. I can't imagine it's any less of a vote winner in the people's hearts back in the UK. It's just whether the system allows that to come to the forefront. Is that a fair comment?
Yes, and we actually in every single party have found support, and it's important to say, because there are, you know how this works. We've got this ADHD is we're everywhere, and people impacted by neurodivergence are everywhere, and so you find allies in unexpected places, and so it's definitely not clear cut. And what's being said at one level is not reflected at others. So I think we are definitely going to make it a political thing. I think we showed ourselves as a political force when 14,000 people wrote in 14 days to their MP. We need to do more of that, and I think with that we can get change. But it's definitely Yes, definitely a plan.
Mel, I might sweep back to you in terms of the diagnosis pathway and the costs and what's involved. I mean, it's fair to say that whilst initiatives like GPs being trained will reduce the waiting time to get seen and assessed, it's still a reasonable waiting time and they're still not inconsiderable costs. Is that a fair comment?
That is, yes, absolutely. And I've just put a little bit of a PowerPoint presentation up, Rob, because I think it's quite good just to, if we can bring that in, talk about some of the, and I don't know if you can bring that in, but talk about some of the differences that we have, which is the public pathway and the private pathway here in Australia. And one of the things I think just to call out here is our two pathways, but yes, there's
Mel, could you just hit, could you put slide presenter, that little button next to the slidey button? That'll enlarge it for us.
yeah.
Slideshow presenter mode.
Oops.
Yeah.
Sorry, slideshow from the beginning. Sorry. Is that
Sorry.
better?
Henry, if you can call up the...
I don't think we're quite there yet. I think we can share it.
Is that better? I've done it now, so you should be able to see, hopefully.
Yes.
Oh, okay. Is that better or not?
You might need to share a different screen, the one that's big.
Okay.
But
Okay, I'll try sharing again. Bear with me a second. 2 seconds, because I know we're stuck for time, so I don't want to be taking all the time on the showing of this. I can definitely talk to it. So I'll try one more time, but if not, I'm going to talk to it and just go with that. But basically, we have two. We have basically the private and the public. And look, we're still faced with significant challenges. So, you know, the diagnostic access is really still quite problematic. So we have, it's via GP referral. Generally getting GPs to make a referral, people can get in to see the GP, but the difficulty is public psychiatrist or pediatrician. The wait times can be between 6 to 18 months. So it's quite significant. The private pathway, there's direct access to private specialists, but there's still significant wait time. And while some people can get in between 2 to 8 weeks, the cost of that is quite significant. And in some cases, the private pathway, people actually having to, or choosing to, should I say, travel from one state to another to actually get that diagnosis. So cost is more, and the actual ability to get to people is quite significant. The cost of diagnosis ranges. So, whilst the public pathway, GP visits are covered under, we have a Medicare scheme for those that, are able to access Medicare. Everyone can access Medicare, but those that choose to do so through the Medicare scheme. And then basically it's referred to a public psychiatrist or pediatrician. The assessment may be free in some cases for younger people or at low cost, but the wait times is significant. So again, it's the wait times, and here we're looking still at 6 to 18 months. In some cases, it's even longer. So people are not actually getting what they need when they need it. The cost to go private is absolutely, I'm going to say, ridiculous in some cases, particularly for those individuals from low social economical background. We're talking between $600, roughly about £300, to basically $3,000, £1,500. Sorry, I don't know that in Singapore translation, so please excuse me. So I'm not that, I don't have the ability to do that, but it's a high cost. And in some cases, I've known people to pay up to $9,000 to actually get a good diagnosis and actually to go with some of the leading psychologists. Treatment options are still limited. So limited due to clinician availability. Clinician availability is significantly challenged, particularly as well in rural and remote regions. So in Australia, we are so spread out. The travel that people have to do to actually get access to a clinician is quite significant. And in some cases, if you're rural and remote, you might have to travel 3-4 hours to come into a metro area. The medication is available through pharmaceutical benefit scheme, but as we know, we've got challenges with access to medication at the moment. So it is subsidised under the pharmaceutical benefit scheme, but access to things, medication is just, is a real challenge for us here in Australia, and I know globally.
Mm.
We've got problems where people are saying that they're trying to go to their prescribing doctor to look for alternatives. They sometimes need different strategies as well to implement, because medication is just not able, they can't access it, having to drive far and field. So in the private pathway, it's the same. There's medication via the pharmaceutical benefit scheme, and also some people pay private. The advantages for the private pathway, it's affordable, it's regulated, and it's integrated with the public health. But the cost of that and the waiting of that and access to that is, I'm going to say, in some cases, near on impossible for some people. And sadly, the private pathway, unless you're somebody that has the ability to do so financially, yes, it is more
Mm.
flexible and it's tailored to individual needs, but the ability to access that is still challenging, but financially for many is not possible.
Mm.
So
Well,
the
thanks for that.
advantages, yeah,
I think we've got about
you,
another 10 or 12
yeah,
minutes. So we might, if
no,
you
not
don't
a
mind,
problem.
Mel, I'll
Yeah.
move on to Darren, and then we'll move on to
Mm.
Moon Lake. All right.
Mm.
So in terms of diagnosis in New Zealand, effectively, if Melissa could put up a slide, it's exactly the same with a different cost structure. I get suspicious when I see things like that because I wonder how the colleges really work together. But as I mentioned before, the pathway moving forward is a GP, if they're unable or haven't had the training, they'll be able to refer to a special interest GP. And they will start that process from there and do the diagnosis. There's one thing I feel I have to mention. This is where all our media conversations about. It's not a 15-minute meeting. So they'll have a prescribed process, might be a couple of 1 hour or 2 hour meetings. So that's really important. It's not that quick 15-minute interview, which is good. The second aspect I should mention is the GPs will have a supervisory psychiatrist as well. The way I've been describing ADHD is like your typical bell-shaped curve, where there'll be some that won't need help or medication. There'll be some in the middle who could go with the GPs, and there'll be some who are quite complicated and who present with a range of comorbidities, and they're the ones that can be referred to a psychiatrist. Now, the big advantage of the change that is being made is we're freeing up a lot of psychiatrist time. So we're hopeful that for those that need to see a psychiatrist, will be able to get much quicker access. Typically in the public sector is those who have mental health issues as well. I should also mention that one of the big issues in New Zealand is our mental health sector is under pressure, like in many places, and even freeing up their time from doing diagnosis for those with ADHD, been pushing that to GPs will free them up for other things as well. The one thing I didn't mention, a change which is already in effect, is about the prescription of medication. So in New Zealand, up to a few months ago, if you got prescribed ADHD medication from a psychiatrist, every 2 years you had to go back and prove you still had ADHD. I can't say that with a straight face. It's particularly frustrating if you're a child or a teenager with ADHD, because you'll find when you go back, they'll suddenly say, hey, you're an adult, so you have to go start the process again. That's what's been removed as well. And the other aspect that I should mention, that there are safeguards built in terms of the checking of clinical notes by clinicians, and also the the checking of blood pressure and things like that are built into the system as well. Will our GPs be able to quote? Like everywhere, they are under pressure. So it will take a while to build it up, but we're really excited about the change. One thing I didn't note that as nurse practitioners also will have the green light to be able to diagnose and treat ADHD under supervision, which again is a big step forward. Many of our nurse practitioners here are more experienced with neurodiversity and ADHD than some of the doctors. This is where I think, oh, who's watching? But I think that's an important first step. The other change amongst all of this is how we're talking about ADHD, and that it's a health issue. And when I reflect back of 5-6 years ago, it wasn't talked about as a health issue. So it's been really positive few years. I have to admit, one change we did get through is, we got this through a change of government from a left-leaning Labour government to a right-leaning National government who weren't too sure what ADHD was. So all credit to the respective governments as well.
It's encouraging to hear, Darren. Terrific. Moonlight, bring us home.
Thank you. I actually prepared a slide, but I won't share it because I think Melissa did a great job. And her slides pretty much, as Darren said, covered very similar. So we know that at least these 3 countries have very similar pathways. So I'll just add the more localized information. So in terms of the subsidized route, which goes through the government polyclinic before the specialist hospitals, at a subsidized fee, it could be as low as Singapore $45 for the consultation, which I think is about similar with Australia. The currency exchange, UK maybe 1.7, but I should have checked before I went online on the air. But for the private side, and the good thing about the public hospitals is that there are 2 routes, a subsidized route, and also you could see someone in the public hospital as a private patient. That means you pay a little bit more, but you can choose who you see, and it's a shorter waiting time. So I call it a bit of a hybrid kind of mode, and I'm actually seeing my psychiatrist that way. The other way is the purely private clinic pathway, which is a much shorter waiting time, sometimes as early as the next few days or next week or so, depending on availability. However, of course, fees will be different. So let's say, for example, a psychiatrist's fees would be probably about 300 Singapore to 350 for a session. For the psychological assessment and testing, it could go up to about 3,000 in some cases. So that's still going to be a bit of a reach for many families, particularly if there's more than one person in the family that needs to be assessed. Medication also is still
it's likely that there is, isn't it?
Yeah. So what we're trying to do about this is that early on when Unlocking ADHD first started, and we were actually in regular meetings with the different ministries and also the public institutions, we learned very early that there aren't enough psychiatrists in Singapore for the population needs, not let alone those who are familiar with ADHD. So it's really no point complaining about structural issues that you can't change in the next few years. So I did ask at that time, what can we do? And the answer was ADHD literacy, or rather psychoeducation. So that's what Unlocking ADHD has been focused on, because people still need support while waiting for the appointment or in between visits. But alongside from that, with the Singapore government's move towards supporting mental health, they've actually targeted by the year 2030 to increase the number or the percentage of psychologists by 40% and the percentage of psychiatrists by 30%. And there's also a graduate diploma in mental health for general practitioners. So all these are moving. I still think it probably more needs to be done, but at least, again, we're starting to move somewhere. So I hope that there'll be more done. And I would love to speak separately with Darren about this nurse practitioner idea. I want to find out more. And definitely with Melissa and Darren about the side as well. Yeah.
It's precisely why we have these forums.
Yeah, and one more thing to add. Sorry, Rob. So what we've done is that we've incorporated on our website in our Restart Starter Kit for Adults, that's free download, the WHO Adult ADHD rating scale. So that for those who are not able to access a formal diagnosis, at least they could do so-called a self-assessment first, and at least know after that to seek maybe the non-medication type support, strategies while waiting, so that you don't have to be left without support.
Very good.
Yeah.
Very good. Well, I'll leave it to you, Henry, to bring us home. Hopefully we're close to time as well.
No, we're doing a great job. Right. I took my homework to create a slide, and I think the thing that's immediately obvious compared to you all talking how Melissa's model, all very similar for each of you and relatively straightforward, and then there's ours.
That's why I moved from the UK, Henry.
No rest for the
Challenges.
We don't have time to start that discussion. I mean, it's absolutely chaos. So we've got 2 sort of core, either go NHS, go privately, we've talked about in private pathways, you self-refer, you don't need the GP, so different for, I think, in the cases you talked about. Sometimes you're screened, so we know one very large ADHD assessment provider, they'll do a screening before they take your money, and they actually will say, say around 75% of people, they don't meet the initial criteria, they don't take the money, they don't assess them. When we're talking about that dialogue of people going, the challenge on people self-assessing online, going, I think this is me having read stuff. Like, there's a huge benefit to that because people recognize ADHD themselves and come forward. But there is also the problem that some of those conversations aren't saying how serious ADHD, the level that's needed, and so people self-diagnosing incorrectly. And it's a very, very difficult conversation. Okay, then you get assessment. You guys talked. So we have already expanded in the UK. So you can be seen. You can be seen by a psychiatrist, a clinical psychologist can diagnose. We also have nurse practitioners, so they're nurses who've got taken additional training to become prescribers. We also have that for pharmacists, so pharmacist prescribers. But if you're a GP, you can't assess. There is a new course that's been developed by the Royal College of GPs. My understanding is no one's done it yet. And so you've got this sort of messy. It has to be a specialist, but it's a wide group. When we've talked to the people who actually wrote the NICE guidelines, who put in that criteria, a specialist but didn't specify, they say they did that on purpose because they knew that the level of psychiatry isn't substantive enough, is already overworked with the work that's there, and that the different options were going to be needed, and so they built that into the NICE guidelines. And then you've got, if you go down the NHS pathway, you have to have the GP referral. I talked previously before about right to choose option versus local. The local, though, does something else often. It triages. I was invited to go to a select committee in Parliament, and when I spoke about triage, I just said the thing about triage, because people hear is, oh, we just segment on need. We see those in, if this is an ER, the people who have got their leg chopped off, we see them first, and the one going, I've got a sniffle, we see them last, but everyone gets seen. But that's not what happens here. Because of the overwhelm of the system, and the system's not fit for purpose, if you're not triaged into that top group, you're not getting seen. And that means you're not getting supportive medication, and what that really means is you can only get seen once you hit crisis. Are you at risk of suicide? Are you at risk of harm to yourself or others? Or are you at risk of having your family breaking up in family court? That list is the actual triage list for an area of Yorkshire. Risk of suicide, harm to others, family court. And even despite that, it took them a year to see the first people on that list. And we're seeing more of that come in. Then you've got a 12 to 2,000 year wait assessment by all the different providers. Sometimes we see a second medication wait. We see that quite often in the local system. And that can be like a person in my family had to wait 3 years. So they got assessed in their first year of university and didn't get seen till the last year, didn't get medication till the last year. Entire life trajectory changed. And then we've talked about the industrial dispute. Yeah, I think I've covered it, but we covered a lot of it before. I'm obviously aware of time. I don't want to muck your MCing up.
Well, I'm glad we don't have those challenges. There's a lot to say, but we all do have our challenges as well. I think it's terrific that we can share this information as well. I think it's also fair to say, Henry, in the next week or two, a lot of the presentations that have been done yesterday and today will be up on websites and available for people to review. And I would invite viewers from all countries to be able to access those sites and watch these videos again. Is that fair?
That is, and they're all on. They'll all be on YouTube, as you all know, because I've been here before. We segment them up and put them up onto YouTube afterwards, so people can go back and see them. It's a delight having everyone here. Like it's our annual get together.
It is.
It is.
One day, right? In person. I met Melissa, right, last year. So and I hope the rest of you. next year. So hope to see you. Yeah.
Henry, it's so good of you to host us. It's wonderful to
Thank
be part of
Well,
this.
we host it together, as you know. I think it's a wonderful collaboration, and it's a big deal. This conference is very special, and actually, we can take a moment to celebrate it because we all come together and contribute in our different ways. And obviously, Australia and UK taking the streaming lead, and we get extraordinary people giving their time for free, and allow us to get information to people and to celebrate ADHD Awareness Month in a really positive way, in a way that helps change people's lives. This is now the 4th year. It keeps getting bigger and bigger and bigger, and it's wonderful. Like, genuinely, it's wonderful. Yesterday, you'd expect me to be exhausted, and I was just so happy. I'm looking forward to today. Ask me what I think.
Yeah. The interesting thing, Henry, when we first did this, and I remember 3 years ago, we met, and there was a couple of weeks to pull it all together for the UK, for the Australian team, should I say, because we obviously wasn't part of it then. And in true ADHD style, we went, okay, we can do it. And 2 weeks later, we've got this big global conference. And then from then, Rob said to me, right, what we're going to be doing now is we're going to be making sure that we're more planned. And then last year, what was really interesting was a little bit more planned, but we still did somewhat procrastinate. And then this year, Rob was like, no, we're getting this in order. And for the first year ever, thank you to Rob. And this is why we celebrate diversity and need people that are neurotypical in our team, because if everything was left to true ADHD Melissa, it'd be procrastinating right until the last week and the global conference would come out. But thanks to Rob and the team, it's helped us to be able to bring it all together. And, Henry, as always, the amazing presentations by the UK team, and fantastic. And it's just great to get to see everybody again. Moon Lake, definitely we're going to get to meet again in person. It was great when we got to catch up in the States, and one day we'll get to see yourself, Darren and Henry, and I'm sure we'll be talking all things ADHD and comparing countries. And I'm hoping by then, Henry, the UK's come on a little bit more.
I mean, it's going to be exciting times. Genuinely,
weird.
like the next few months are going to be a big deal. We're about to kick off a really big legal push, which we're talking about in the last hour of our segment. And if we're successful in that, we'll have changed everything. But I can tell you the government will not want us to be successful because it has some knock-on impacts for their metrics. But I think the big issue, which I think we all have to fight, which is defeating the issue, that the idea that ADHD people are just an expense, that we're broken, and in fact that we can be amazing and do extraordinary things. But an assessment, the understanding that brings, the medication intervention for those that want it, are game changing. And but certainly in the UK, we've got wait times. We've always got that one at 2,000 years, but over 10 years is not uncommon. And we have other problems that when you turn 18, you get past the adult services and you get dropped, and you get put to the back of the queue. We snatch. And actually, that's what is happening right now. We're snatching victory. We're snatching, I'll get it the wrong way around, snatching defeat from the jaws of victory. We're actually progressing here, but it's being reversed. It's listening to you is wonderful, hearing the positive side. And hopefully next year we can join you in saying we've had progress.
Well, we'll be here and we'll have that conversation.
Right, who's going to do the sign out from Australia? It's time. Well, so who wants to do the goodbye? Melissa?
Yes, look, I just want to say absolute huge thank you to everybody across the globe that today has listened and participated in. For those individuals that will be after as well, because I know some have been sleeping during the period of time, I want to say a huge thank you to you, Henry, the dedicated hours that you've given to ADHD Australia to make this happen. And Moon Lake, Darren, it is absolutely amazing to hear your stories in your countries and hear a bit more about what's happening and actually how similar we are over here in Australia. So, but look, to finalise, I just want to do a call out to the ADHD volunteer team. This conference would not happen without you, Rob. Your dedicated hours upon hours of every single moment of, what you have given to ADHD Australia. We also have Matt Cameron behind the scenes. People have not seen him, but he's been tech all day and, constantly working exceptionally hard. Andrew, that you've got to see at various different points, and many, many others. But this is a real team effort, and it could not have happened without of all of our volunteers. We've had exceptional speakers, and I want to just do big shout out to every single professional today, whether that be a carer, a person with ADHD, a professional, all of our medics, our researchers, everybody that's come in to do the conference for us and to educate the globe. So thank you so much. We are really, really excited for next year. Maybe we need a bit of sleep before then, but we will be here again next year, and hopefully we'll have some more countries join us as well. So thank you, everybody.
That's us signing out. For Australia and UK officially taking over. Thank you, Darren. Thank you, Moon Lake. You guys are amazing. Wonderful to see and congrats on what you've been doing. Melissa and Rob, ADHD Australia and UK, we do this together. We do each other's respective nights and operate in the days, and it's absolutely wonderful. Like, the reason this has this energy is this ridiculous idea that we just live stream. It was 24 hours, now I think it's 28 hours. And we're ruminating on making it even longer next year.
We'll have to clone a few people, but yes.
And it gives it an energy that brings people in and has and is wonderful. So thank you for, well, it's great. I love doing this with you. So brilliant. And time for us to take over. So goodbye, Australia.
Bye.